Welcome to another production by the Millennial Mechanical Therapist. Your hosts, Dr. Joseph Gravino and Dr. Clay Case, are two physical therapists trying to treat health issues mechanically. Listen further for patient cases, guest videos, advantages and disadvantages of the way they practice, and much more. Thanks for tuning in today. Check us out on YouTube, Facebook, and at our website. We hope that you learn a lot from watching this video and you come back for more.
Hello, my mechanically minded friends. I am the Millennial Mechanical Therapist, and today we're going to talk about why the assessment is so important. So the other day I had a evaluation come in of a younger gentleman who had a script with a diagnosis of Osgood-Schlatter's. Now, not uncommon for young athletes to get this type of diagnosis. And when I see something like this come in the clinic, a lot of times I'm thinking to myself, is this mechanical? Is this not mechanical? Is it truly the pathology that the doctor or the physician has specified? Is that truly what's going on? So it's not that I don't like these cases. It's just I come in with intrigue on, am I going to prove that the physician's diagnosis was correct, or am I going to kind of see something different? So it's a little bit interesting. In this case, I'm bringing up for that point specifically. So younger boy, around 13, 14, comes in with anterior knee pain on his left knee only. Happened about 3 months earlier. And now a little history on the boy is he plays football, basketball, and baseball. So he really doesn't ever have a time off, which, again, classic. Age is classic for this type of diagnosis. And it's worsening on him the more he goes. He hasn't really stopped athletics, though, so that really, speaks to that as well. But there's some things that seem weird. He really didn't have an insidious onset of pain. He kind of knocked knees with somebody in a basketball game back in January, and that's when he can attribute the pain to it. Take that for a grain of salt. But since then, he really blames that. He really doesn't have spinal-like symptoms. There was no paresthesia, nothing in the thigh, the low back, no history of low back pain, neck pain, anything like that. Doesn't mean we didn't look, though. So, just throwing it in there. Sidebar. Better worse section, you can find this. This will be linked up with the video, but he was worse rising after sitting for a while, which is a little different. Sounds more like spine. The first few steps after sitting and rising was worse. But then the only thing that really bothered it then was running, jumping, squatting, and kneeling. However, he did state that generally movement and more movement eases his pain, and he's better for it. He did note that there was swelling at some point in time in the very beginning, and now not so much. I think this was about 3 months after. And he also noted intermittent clicking and popping inside the knee, which doesn't sound so much like Osgood-Schlatter's, but, everyone had, whatever. I don't take those, again, grain of salt. I don't take that personally, or I don't think about that too much. No real red flags on this kid. Whipped right through that type of stuff and went right into the mechanical evaluation. He was pretty clear. His posture was poor. What 14-year-old's posture isn't poor? Postural correction did nothing for him. Sitting there, he had no discomfort whatsoever. So, we didn't create any pain. When we looked at his movement, really end-range flexion of the knee brought on some discomfort, and then resisted extension. So, sounds kind of like it could be Osgood-Schlatter's. We looked at the spine, clear. Kid had nothing. I made him flex like crazy and nothing happened. What I did do was I found a baseline, and this is so important. So we have the baselines of end-range pain with passive flexion, and extension, resisted extension has pain. There really wasn't any big movement losses of the knee, so we couldn't go with that. But he said squatting really caused him a problem, so I made him squat in front of me. Besides the fact that his squat technique was horrible, it produced pain. So I started with flexion, and flexion of his knee did nothing in the unloaded position. So we brought in overpressure, which gave him a produce no worse outcome, or produce no worse symptomatic response, but then his squat got worse. So we went into extension. Active extension decreased and better the pain, but had no effect on the squat. So I killed extension for a while, and he really didn't, he just kept getting decreased better, but no effect on squat, decreased better, no effect on squat. We didn't abolish ever. And then finally, we made our way into, active extension with the foot on a stool. So pretty much like a hamstring stretch or a quad set, right? But a vigorous quad set from an already extended position, that was decreased better almost to nothing. It wasn't abolished, but it was very low. And his squat improved dramatically. So I sent him home with that, which is nuts. If this is truly Osgood-Schlatter's, then I should get a produce no worse every time I'm stressing that tendon, that ligament, and nothing's going on. Produce no worse, produce no worse, produce no worse. Yet I got a decrease better and improved his squat and pain with that. Not blaming anyone for diagnosing with Osgood-Schlatter's. His age, his athleticism, the knee, the type of pain, the location of the pain, all looks like it could be Osgood-Schlatter's. It's screaming Osgood-Schlatter's, except when you put him through a mechanical evaluation, it's not. Saw him again after, and he was better. Now, it wasn't all gone, but he was much better. Squats were more tolerable. The kid's going to be fine. He's an athlete. He's growing. These things happen. So he has a small derangement in his knee. He's going to get over it. But if he wouldn't have gone to someone who's mechanically minded, who took the time to put him through a mechanical evaluation, a McKenzie evaluation, he probably would have gotten stretching, strengthening, and ultrasound for a long period of time. Not that that's bad, but man, how much faster can we get this kid playing again? How much more knowledge and education can we get him that hurt doesn't necessarily mean harm, and that he needs to take care of himself and his joints, especially when he's playing 3 sports. And that's hard for a 14-year-old kid to grasp. But man, the mechanical evaluation gave this kid power to get back to being an athlete, to get over this, and didn't give him some devastating diagnosis that for the rest of his life he's going to deal with knee pain until he finally stops growing. Off my rant. End rant. Moral of the story, my friends, everyone deserves a mechanical evaluation regardless. Everyone. I truly believe that wholeheartedly. Even if you get nothing from that mechanical you can't get nothing from that mechanical evaluation. If you can't find a direction of preference, if it doesn't sound like it's a dysfunction, if it's not a postural syndrome, and it doesn't even fall into typical other categories, that person probably doesn't need to see you. So you can never not get something from a mechanical evaluation. You can only get information. All right, friends. Thank you for joining me today. Follow us on Facebook and find us on our website. Move your patients early, move them often, and move them to end range, my friends, because that's where the magic happens. Thank you, and I'll catch you next time.